Buenas noches a todos los asistentes de este seminario. Yo soy Félix Suárez, editor en jefe de Editorial Amolca. Les hablo desde la ciudad de Medellín, Colombia, donde se encuentra la casa matriz de la editorial. Y hoy estoy muy contento y complacido de poder presentar este seminario que se titula Bloqueo epidural caudal simplificado, una guía práctica paso a paso, que estará a cargo de toda una autoridad en la conceptualización del tratamiento del dolor en los pacientes, una figura representativa en la anestesiología en el mundo, el doctor Steven Waldman. And Dr. Waldman, I'm very pleased to introduce you today. How are you?
I'm great. I'm so happy to get to talk about one of my favorite nerve blocks, caudal epidural nerve block. It is uh, it is really at the top of my list. It's a go-to nerve block. It has tremendous utility and such a privilege to be here. So uh, it's always more fun to get to talk about something you're enthusiastic about. And I love caudal epidural blocks.
I'm very sure that it's a privilege for people to hear you today. And well, I don't know what information you will share with people tonight. Bueno, yo quiero presentar hoy también a un invitado especial que estará acompañándonos como interlocutor de la especialidad con el doctor Waldman, el doctor Silver Balcázar de León. Un gusto saludarlo, doctor Balcázar. ¿Cómo está usted?
Hola, ¿cómo está? Buenas tardes. Honrado de estar con ustedes y pues apoyar en lo que se pueda. La verdad es que es un honor estar al lado de un referente mundial, uno de nuestros héroes en la medicina del dolor. Creo que cualquier médico intervencionista del dolor tiene por obligación la lectura del libro del doctor Steven Waldman. Y todos seguramente quienes nos dedicamos a la medicina del dolor hemos leído este libro. Hi, Dr. Steven. It's a really honor for me to be with you because you're a world reference in interventional pain management. Thank you. Thank you for the invitation.
Well, thanks for letting me speak.
A mí me honra mucho tenerlos acá y bueno, que nos puedan acompañar en este seminario. Doctor Silver, sé que está un poco ajustado de tiempo en este momento, así que esperemos, bueno, poder cumplir también con los lapsos que podamos tener y bueno, que podamos escuchar al doctor Waldman. Bueno, les comento que tenemos participantes de prácticamente toda Latinoamérica. Doctor Waldman, you have a great audience today. We have participants from all over Latin America, from Argentina, Bolivia, Chile, Colombia, Mexico, Peru. You have a very diverse audience today, Dr. Waldman. Doctor, I'll make a brief introduction in Spanish for the attendees. I also explained that they can turn on the subtitles and then I'll give you the floor. Is that okay with that?
Sounds great.
Ok. Bueno, quiero explicar brevemente la organización de este seminario. Primero daré una muy breve reseña de nuestros invitados de hoy. Después le cederé la palabra al doctor Waldman para que nos hable del bloqueo epidural caudal simplificado, que es el tema de hoy. Mientras el doctor Waldman va haciendo su presentación, ustedes pueden ir haciendo sus preguntas a través del chat que tenemos disponible en esta sala. Y al terminar la presentación, el doctor Waldman irá contestando sus preguntas con el apoyo del doctor Balcázar. Les comento que la plataforma Zoom tiene una opción de subtitulado automático. Pueden activarlos en la opción que ven abajo en la plataforma que dice Captions. Verán una pestañita en la parte superior de esa opción. En la opción My Speaking Language, activen la opción English y en My Caption Language, activen la opción Spanish o el idioma que quieran leer en la traducción, ¿no? De todas formas, bueno, en los próximos días compartiremos la grabación de este seminario para que puedan escucharlo con calma. Y bueno, nada, no quiero seguir extendiendo la presentación. Yo quiero presentar primero diciendo al doctor Waldman, pues diciendo que él es un anestesiólogo reconocido internacionalmente, educador y un autor prolífico en el campo del manejo del dolor. Ha escrito más de 50 libros y 240 publicaciones revisadas por pares, muchas de las cuales se han convertido en referencia a nivel mundial. El doctor Waldman tiene una amplia experiencia como clínico, líder académico e innovador y ha formado a generaciones de médicos en técnicas intervencionistas para el manejo del dolor. Actualmente se desempeña como profesor de anestesiología y humanidades médicas y bioética y es ampliamente considerado un pionero en el avance de técnicas seguras y efectivas de anestesia regional, incluido el bloqueo epidural caudal. También, pues ya les dije, el doctor Silver Balcázar de León es anestesiólogo con subespecialidad en medicina del enfermo en estado crítico. Cuenta con una alta especialidad en algología intervencionista. Cuenta también con un fellow en práctica intervencionista del dolor, certificado en ecografía intervencionista del dolor, en medicina del dolor y musculoesquelético y con certificación otorgada por la Sociedad del Nervio Vago. Entonces, bueno, ya podemos empezar a escuchar al doctor. Doctor Waldman, welcome again, and the audience is yours.
Okay, so caudal epidural block, again, one of my favorite blocks. I love doing it. It has tremendous utility. And we'll talk about indications. We'll talk about hands-on how to do it, how to dose the local anesthetics, and then save plenty of time for questions. Really talk about anything pain management, anything interventional. So let's go ahead and get started. So the indications for caudal epidural block, very broad, very broad. So unlike transphenoidal pituitary adenolysis, retroglycerin glycerol, procedures that have a very specific but limited utility, this is really a great nerve block to have in your bag of tricks when you're taking care of patients in the operating room, in the obstetrical suite, in the emergency room, in a rural, under-resourced setting. This is a go-to block. It's really great. So it's great in adults, it's great in peds. We'll talk about that more in just a minute. In the operating room, caudal epidural block with local anesthetic can provide great surgical anesthesia for any pelvic, genital, perineal, rectal, anal surgeries. It really is a great technique. It's a simple technique. I like it really well when I'm in a low resource setting where I may not have all the monitoring or the backup staff if something goes wrong. I see it as one of the safest surgical anesthetic blocks out there. Caudal's been used forever in obstetrical anesthesia. In fact, my mom had a caudal anesthetic when I was born, which probably explains a lot about me. Really in favor up until the early 50s, then as lumbar epidural and as local anesthetics both improved, it kind of fell out of disfavor. It's again experiencing a resurgence, either alone as a standalone procedure for patients that's getting toward the end of labor, but you've got to use forceps or you've got to do a large episiotomy, or they're just having a lot of pressure and pain, or combined with lumbar epidural. I'll remind you that with the caudal epidural block, you don't get the sympathetic blockade you're going to want for the top of the uterus in obstetrics. So just something to think about. But boy, out in a low resource setting, this is a great technique. And I think a very safe technique. We'll talk about how to avoid complications and how to safely dose local anesthetics in just a minute. You can use caudal for those of you that are seeing patients with chronic pain. If you're seeing patients with chronic pelvic pain or calgia, vaginal pain, clitoral pain, labial pain, rectal pain, perineal pain, kind of your first, in my opinion, the first go-to block is a caudal with local anesthetic. And if you really are generous with your local anesthetic and the patient has sensory deficit and they're still having pain, the one thing you know for sure is doing neurodestructive procedures, probably not a good idea. Probably not a good idea. So differential neural blockade, either using different concentrations of local anesthetic or blocking specific anatomic structures, a good idea. For patients where you're thinking about destroying sacral nerves, somebody that has sacral tumors, bad endometriosis, something like that, it can give you a prognostic indication of is destruction of the sacral nerves going to work. For acute pain, it's a great procedure. It's a great procedure in the emergency department. It's a great procedure in the office. For people with acute pain, and for people with pelvic trauma, lower extremity trauma, acute pain emergencies, you know, somebody that's riding a bicycle or motorcycle and gets a straddle injury, a great option that can provide very, very, very effective acute pain management. Acute herpes zoster, acute vascular insufficiency of the lower extremities. And for people with bad hidradenitis suppurativa of the groin that are really, really suffering, this is a great technique while you're waiting for other analgesics to take hold. For chronic benign pain, anybody with lumbar radiculopathy, I generally start with a caudal. I probably shouldn't admit this to the entire Latin American population, but it's so simple, it's so straightforward, it is so complication-free, no risk of a wet tap, I mean, essentially no risk of an inadvertent dural puncture, a wet tap. It's a great starting point, especially in a patient that's anxious about needles, because you can do a caudal with a 25 gauge 5H, inch-and-a-half needle very easily. Radiculopathy, anybody that with spinal stenosis, reflex sympathetic dystrophy, any type of pelvic or perineal genital pain, it is a great starting point. Cancer pain, again, any pelvic cancers, genital cancers, a very reasonable, both diagnostic and when you add steroids to local anesthetic, therapeutic. It's amazing how 120 of methylprednisolone with your local anesthetic in somebody that's got metastatic disease from prostate cancer can be very, very effective in getting quick relief, can be reasonably effective with chemotherapy-related peripheral neuropathy as you're adding gabapentin or other drugs. Absolutely, the starting point for somebody with that's had previous lumbar spine surgery that has radiculopathy, I'm going to start with a caudal. And we published many years ago a large prospective study looking at anticoagulated patients, and generally you don't do neuroaxial anesthesia in anticoagulated patients, but in somebody with coagulopathy that's got metastatic prostate disease, you can do a caudal, albeit with some risk, using a 25 gauge needle. And we'll look at the anatomy in just a minute. I can explain why it's so much safer than a lumbar epidural. So as with every regional anesthesia technique, with every interventional technique, it's all about the anatomy. It's all about the anatomy. I know we've got, for the anesthesiologist, I'll apologize. You know this anatomy. For the non-anesthesiologist, you learned this anatomy in anatomy class, but you may not remember it. So a caudal block is simply an epidural block where you're placing the needle down lower into the caudal canal. So the epidural space is the space surrounding the dura. When you do a spinal anesthetic, you put a needle through the skin, subcutaneous tissues, some muscles, some ligaments, through the ligamentum flavum, the big, large, yellow, very dense ligament, through the epidural space and through the dura into the subarachnoid space. When you do an epidural block, lumbar epidural, thoracic, cervical, or a caudal, you're putting the needle into the space just outside the dura. So you're bathing the nerve roots as they exit the dura with local anesthetic. Here you can see the caudal anatomy. So again, for the non-anesthesiologist, the important anatomy is the sacrococcygeal ligament, which gives us access to the caudal canal. But here you can see the dura ending. Here you can see the epidural space. And this is contiguous all the way up to the upper cervical spine. And our goal is to pop a needle through this ligament into this space and inject a volume of local anesthetic sufficient to treat the nerve roots that we're interested in treating. I mentioned just a moment ago that I'm pretty comfortable doing a caudal with a 25 gauge needle in an anticoagulated patient. Ideally, if you can avoid sticking a needle in somebody anticoagulated, that's your first best choice. But if a patient is suffering, I think that the risk to benefit ratio is acceptable. When we do an epidural in an anticoagulated patient, our risk, because of the venous plexus, the epidural veins, and some small arteries, if we traumatize those and the patient can't clot, you can get an epidural hematoma. Not good, and really not good in a low resource setting. You know, if you're at a big tertiary care hospital and you've got the neurosurgeon standing by, maybe you'll do okay, the patient will do okay. But in a low resource setting where it's just you and the patient, you've got to be careful. You'll note that this venous plexus really attenuates the further down you go below the dura. So we're going to put the needle right here. That is not to say that there aren't veins here. And for those of you that have done a lot of caudals, you know you aspirate before you inject, and every once in a while you get blood. In my entire career, and I mean, I've probably done 25,000 caudals, maybe more. I have only aspirated spinal fluid one time. So just something to kind of think about. Now, there's a lot in the literature about the variation of the sacral hiatus. Here you can see this elongated one. Here's kind of an asymmetrical one. Here's one where the sacral cornu is partially blocking. Here's another asymmetrical one. While this is correct and is of interest for the anatomist, from a practical viewpoint of performing the procedure, really not an issue. And if you're using image guidance, either fluoro or ultrasound, really not an issue. But even using a landmark technique, just doing it with no image guidance, you should have a 99.67 success rate. So here's how to do caudal block. Positioning the patient is key. So I'm going to show you the prone position first, and then we'll look at the lateral position. So with the prone position, we'll put a pillow underneath the patient's pelvis, and we're going to have them turn their heels outward. As you can see, you know, if I'm laying on the pillow and Silver's coming at me with a big 18 gauge needle, I'm going to kind of tend to squeeze my gluteal muscles. I'm not in a hurry for that needle. So by rotating the heels outward, you can see that the gluteal muscles relax. And that makes it easier to do the procedure. It's worth the extra little bit of time to put them on a pillow, which will tilt the pelvis upward, and then rotate those heels outward. The anesthesiologists in the audience know that the prone position, when you have a complication, is a bad position. Airway management is a challenge. So, you know, when you're putting any patient in the prone position and you're going to inject a volume of local anesthetic, you need to be thinking about, am I going to be able to roll this patient over? Am I going to be able to manage their airway? If you're not sure, you may do better with a modified Sims position. If you're just learning to do this procedure, I will tell you it's much easier to do it prone than in the lateral position, and I'll show you why. You can kind of see in this picture, here's the sacral hiatus, my arrow's pointing at it. Here's the gluteal cleft. So the gluteal cleft, gravity pulls this down. And as you get older, I will tell you, the gravity pulls more down and it goes down further. So you're palpating the, you're identifying the gluteal cleft as your landmark, but it's actually below the sacral hiatus. And I think that's how you can really get into complications. So here you can see the location of the sacral hiatus in a young patient relative to the gluteal cleft. So in the prone position, we're going to double glove. We're going to place the middle finger of the non-operating hand. So I'm right-handed. So my left hand, my little finger of my left hand is going to just touch the tip of the coccyx. Now we know we're down in a contaminated area, so we're going to double glove. In a size 8 hand, 100% of the time, the sacral hiatus in an adult, the sacral hiatus is going to be below the proximal intraphalangeal joint. If you wear a 7.5 glove, it's going to be just above it. If you wear an 8.5 glove, it's going to be just below. So you can see right here, that's where the sacral hiatus is. It's always there. This will never let you down. It will never let you down. Once you identify that point, you're going to take off the contaminated glove, and with your sterile glove, you're going to rock back and forth and palpate that sacral hiatus. Again, if you're teaching yourself this technique or learning this technique, practice identifying the sacral hiatus on your significant other. If you don't have a significant other, on your dog. Dogs have big, huge sacral hiatus. If you have cattle, they have, you can easily do a caudal on a cow. But you'll go, aha, I really can feel this. I know where it is. And that can help. Once we identify the sacral hiatus, we're simply going to place a needle with at a 45-degree angle through the sacrococcygeal ligament. And the sacrococcygeal ligament is a ligament that runs from the sacrum to the coccyx and allows the coccyx, it limits the motion of the coccyx to flex. Pitfalls in needle placement. So I'll talk about each one of these very quickly. If you do not use a 45-degree angle, and this can happen if you don't put the patient on a pillow and you go straight in, you're just going to inject outside the sacrum into the subcutaneous tissue. What that's going to feel like is you're going to start to inject, there'll be a little resistance, and as you keep injecting, that resistance will increase, and the patient is going to start complaining of a lot of pain. Subperiosteal, again, if you're not at 45 degrees and you catch the periosteum and put the needle into the periosteum, there's going to be tremendous resistance to injection, and the patient is going to cry out in pain very quickly. In the bone marrow cavity, again, resistance and pain, but in an, you think, oh, how could that happen? How could that happen? In an osteoporotic patient, somebody with bad osteoporosis, this can easily happen. And this bone marrow is vascular, so you can understand why you don't want to do that. You're going to again feel moderate resistance and then increasing resistance. In the sacrococcygeal ligament, lots of resistance, and the patient will cry out in pain. In obstetrics, if you're not paying attention to what you're doing and you're really pushing on that needle, conceivably, this is right where baby's head is, not good, not good. So something to keep in mind, and that's why I like a short needle. Complications. When we look at the volumes of local anesthetic, we're going to see that intravascular injection of large volumes of local anesthetic can cause seizures, can cause unconsciousness, can cause death, a lot of problems. So we're going to want to be very, and we'll talk about how to inject in just a minute, but we always want to be attentive to intravascular, the potential for intravascular injection. A trick that one of my professors, when I was a resident about 1 million years ago, taught me is, as you're injecting, talk to the patient, have the patient talk to you. So you can say, where are you from? Do you have any kids? You know, what's your favorite, here in Kansas City, what's your favorite barbecue restaurant? And if the patient is absorbing a lot of local anesthetic, they'll go, oh, well, my favorite barbecue right before they seize. So that can help. Again, we talked about needle-induced trauma. If you're attentive to technique, should not occur. Epidural hematoma, I've not seen it in my career with caudal epidural block, and that's doing a fair number of anticoagulated patients too. There's 1 or 2 case reports over the last 50 years. Infection, if you're not attentive to sterile technique, whether you're doing a trigger point, a stellate ganglion block, a lumbar epidural, it's a big deal. I've seen 1 infection. It was when I was a resident. One of my fellow residents got an infection. It was bad. So we really want to avoid that and want to be really attentive. If a patient calls and is having post-procedure pain, first question, do you have any fever? And if they do, you want to see them back immediately. So fluoroscopy can be useful. I would say this, for those of you that are doing image-guided procedures, if your go-to imaging is fluoro, I'm not here to convince you not to use fluoro and to use ultrasound, but I'd use what you're used to and comfortable with. Again, you can do this landmark technique. I don't think the average caudal block requires imaging. If I'm going to go to imaging, I generally will pop over to ultrasound, but I don't consider it as mandatory. And if I'm seeing patients in a low resource setting, you may not have ultrasound or the quality of ultrasound that you want. Let's look at the ultrasound technique real quick. So what we're going to do is we're going to orient the transducer in the transverse plane in the midline, just above the gluteal cleft. So think about the transducer kind of like you're palpating finger. We're then going to slide the transducer in a caudad direction until the two nuns appear. What are the two nuns? So this is where you put the transducer. Very straightforward. These are the two nuns. You see them walking down the street. Here's Mother Superior. Here's the other nun. These are the sacral cornu. My friend Felix says it looks like Mickey Mouse's ears. So if you prefer Mickey Mouse to the nuns, that's fine. Here's the sacrococcygeal ligament. And we're really going to want to identify that, and we're going to really want to identify the floor of the canal. And we do that by rocking the transducer back and forth. So these are hyperechoic structures. They reflect back a lot of sound wave. So by rocking that transducer back and forth, you can easily see the sacrococcygeal ligament and the floor of the caudal canal. If you can see the floor of the caudal canal, and baby's head's right here, there's no reason you're going to go through the floor of the canal. If you can see the sacrococcygeal ligament, you're certainly not going to inject up here. And I've never seen this, but I would suspect that if you put a needle in the sacrococcygeal ligament, inject under ultrasound guidance, you'll see the ligament kind of disintegrate before your eyes. So we're just going to slide it down until we see the two nuns. And then we're going to look for the sacrococcygeal ligament between them. Here you can see an out of plane injection. Here's the needle, and it's going to pop right through the sacrococcygeal ligament. Now, for those of you that are doing a lot of ultrasound guided procedures, in plane, out of plane, I see it a lot like what's your favorite flavor, chocolate or vanilla? I'm kind of, I like them both, but for some people, they only like doing an in-plane needle placement and injection, and that's fine. That's fine. I'll show you how to do it. Simply turn your transducer linear and slide it down the gluteal cleft. Here you can see the sacrococcygeal ligament. Here you can see the sacrum. You can see the caudal canal very easily. And here's your in-plane injection. So for the in-plane folks, great. For the out-of-plane folks, great. For the fluoro folks, great. For those of you that say, I don't need any image guidance, or image guidance isn't available to me in the clinic that I practice in, not a problem. You can use the landmark technique. And here you can see the needle. You can see the ligament. And here you can see the needle popping through. There's the needle tip through the ligament. Pretty straightforward. All right, what about drug dosages? So I mentioned, I probably talked about it too much, that intravascular injections are concerned. So one of the things I think that caused caudal block for obstetrics to go out of favor is lidocaine. You know, the amide local anesthetics are relatively new. You know, our specialty of interventional pain management is a brand new specialty. The lidocaine kind of World War II vintage. Before that, ester local anesthetics, and for caudals, chloroprocaine, 2-chloroprocaine, pretty forgiving drug for a ester, but you're using fairly large volumes here. In adults, that's, you know, 3% chloroprocaine, that's 900 milligrams of local anesthetic. Have done that a lot. Did that a lot as a resident up at Mayo's for rectal surgeries, vein strippings, stuff like that. Lidocaine, probably a little more forgiving. Ropivacaine, if you have access to it and it's available, certainly gives you a little larger margin of safety. I know that Felix is going to share these slides with you, so the dosages are here. Let's look at the PEDS dosages real quick, and then let's talk about how to safely inject. You're going to pick the drug you're most comfortable with. I wouldn't, because Steve says, oh, I think ropivacaine's great. If you've never used ropivacaine and you don't know how to calculate milligram dosages, stick with what you know. That's always the safest. But from a cardiovascular complication viewpoint, ropivacaine's probably the safest. And in PEDS, I think that's the drug that's used the most. That's the drug that's used the most. But certainly, if lidocaine is all you have available, you know, as long as it's preservative free, you're good to go. You can see these are reasonably smaller doses, reasonably smaller doses. So how do we safely inject? Okay, first off, watch your sterile technique. You don't want an infection. It's aggravating to everybody involved. It can really harm the patient. So great sterile technique, great technique placing the needle. When you have the needle where you believe you want it to be, gently aspirate. You should see nothing. If you see blood, you can either reposition the needle. Some people would recommend rotating the needle. You know, I would do what you're most comfortable with. If you see spinal fluid, probably shouldn't do a caudal on this patient. It means their anatomy, you know, they've got a sacral dural cyst, something going on that better somebody else figure out than you. Then inject slowly. Then inject slowly. Some clinicians recommend adding a little bit of epinephrine to the local anesthetic. I'm not a fan of that, but I wouldn't argue there's enough in the literature to support it. If you're monitoring for tachycardia, it can give you good early warning. My vote is just inject slowly. While you're talking to the patient, you'll be good to go. So that's how you do caudal epidural block. My friend Taylor Swift, I'm looking out the window of my office. Believe it or not, I can see the roof of Travis Kelce's house from here. He lives just over the hill, and Taylor is in town this weekend. I don't know whether she's still here, but we love you. Let's open it up for questions. You can ask anything, and if I don't know, we'll ask Silver.
Dr. Waldman, thank you for your presentation, and it's a good way to finish the presentation. Um, um, I got a question, but I'm going to try to explain the doubt I have. But because you said that it's the ultrasound, it's not mandatory in the procedures, right?
That's correct.
Okay. But doesn't it become mandatory when performing the procedure on pregnant patients?
Uh, I, I think it becomes highly, highly, highly advisable. Let me give you a scenario and then you tell me what to do, Felix. So let me back up for a second.
Okay.
I'm giving you Steve opinions. These are my opinions. If you don't agree with them, that's fine. I'm just a guy that's taken care of a lot of patients, and have kind of been doing it for a while. That doesn't mean that it makes me smarter, but it means that I was doing it before ultrasound guidance existed. So my context may be incorrect. I may be confused, and I'll easily admit that. Let me give you a scenario, Felix, because I think your question is a good one. And I do not know the standard of care in Peru versus Chile versus Colombia versus, I know Kansas City.
Mm.
If you're in a clinic in a low resource setting, rural, not much going on, 2 rooms, and a woman comes in and she's screaming in pain, and she's been in labor, and she's for 36 hours, and she's worn out, and you need that baby needs to come out, and maybe she's already looking like she might be getting chorioamnio, she's infected, and I don't have an ultrasound machine, and I've got to say, should I do this under ultrasound? And I keep in mind, I've written 2 books on ultrasound guided procedures. I'm a big fan of ultrasound. Should I do this patient who's in horrible pain, but I don't have ultrasound? What should I do? I would probably go ahead and do the caudal again, and Silver can jump in. He knows the standard of care. If I'm wrong, just say I don't agree with Dr. Waldman, and I'm fine with that. I'm very soft-hearted. Silver, what do you think?
Yes, I agree, doctor. I think that we can perform this procedure with an image technique. Is the most convenience, especially if is the for chronic pain. But you can perform this procedure if your landmark is you can touch it.
Doctor Silver,
Yeah.
¿cómo se hace de repente, o cómo considera usted que debe hacerse, o que podría hacerse, por ejemplo, con pacientes embarazadas? O sea, en ese caso, en
With
México, por ejemplo, hay un tratamiento
yes.
específico.
Yeah. Um, mi opinión, o en pacientes con dolor, específicamente con dolor discogénico, con dolor radicular, me han tocado 2 o 3 casos de este tipo de pacientes, y los realizamos vía ultrasonido, o sea, un abordaje caudal, aplicación de corticoides por vía ecográfica, 100%.
Ok, ok. No sé si quiera, doctor Silver,
¿Sí?
pues, leer algunas de las preguntas y
Ya.
tratar de traducirlas al doctor y bueno,
Yes,
conversar
yes,
un
yes,
poquito
yes, no
sobre
problem.
ellas.
Okay.
Sí.
Okay, doctor. Here a question, Dr. Ezequiel Formica. How is the technique with X-ray? Can you explain me, please?
How is the technique how do you do caudal epidural block with fluoroscopy? Is
Yeah.
that the question?
Yes, yes.
So you're going to place the patient in the prone position as I previously described. Do you want to do it one sentence at a time, Silver? Do you
Yeah.
want to translate?
Yes,
So,
yes, yes.
okay, place the
Sí,
patient.
ok.
Okay, place patient in the prone position.
Debes de colocar al paciente en posición prona.
Image
Ok.
use fluoroscopy to identify the sacrum
Ok,
in
debemos usar fluoroscopía para identificar el sacro
and then identify the sacral cornua.
debes identificar los cuernos sacros.
You can, to confirm the anatomy, if you're not sure of what you're seeing, you can also utilize a lateral view, which may help identify the sacral canal.
Si no estás seguro de la vista en AP, puesto que suele ser un poco complicado, puedes realizar una posición lateral del fluoroscopio para identificar el canal sacro.
The lateral view is useful in identifying where the needle is, the needle placement. You
Sí.
don't always need the lateral view simply to, usually you can identify the sacral hiatus just with the PA view.
La vista lateral suele ser muy útil para identificar la aguja, especialmente la profundidad. Y podría agregar, en mi experiencia personal, que debemos de verificar siempre en posición anteroposterior para identificar que estemos en la línea media.
Bien. Doctor, bueno, hay otra pregunta acá, pues traté de como
Yeah.
de traducirlo, pero no sé si quiera traducirlo usted.
Yes. Yes. Other questions. Good evening. Thank you for your invitations. Greeting from Dominican Republic. My question is, in a patient with a rectal tumor with involvement of the coccygeal segments, how can we make this blockage last longer?
Well, you've got to, so my approach in a patient with a rectal tumor with bony involvement of the coccyx, I would start with acute, just blocking with local anesthetic, because the question I want to, the question I need an answer to is, will this relieve the pain?
Yes. Él iniciaría con un bloqueo solamente con anestésicos locales para evaluar la respuesta y si hay respuesta, seguiría adelante.
If in fact the pain goes away and the patient is, oh, doctor, thank you. The pain is better. Thank you. One option, if the patient, if you're waiting for radiation therapy to take effect or chemotherapy to take effect, is you can do a continuous caudal. Simply place a Husted or a TUI needle and thread a catheter in. You can actually tunnel the catheter for longer term use. Or
Yeah.
you can then move to more anatomically specific nerve blocks to determine if blocking the ganglion impar, ganglion Walther, or blocking a specific sacral nerve root will provide pain relief. Then you can destroy that nerve root and maybe maintain bladder function and fecal continence.
Ujú. Ok, el doctor dice que obviamente este paciente debe recibir terapia con radiación y quimioterapia, pero si el paciente ha presentado mejoría con el primer bloqueo anestésico, una opción podría ser colocar un catéter en el espacio epidural caudal, que se podría usar por un tiempo prolongado Y también podríamos optar por otras opciones intervencionistas como la destrucción del ganglio impar o en su defecto el abordaje de las raíces sacras, valorar si estas pueden ser destruidas o no, siempre preservando obviamente la función de los esfínteres, ¿no? De la vejiga y del esfínter anal. Tal vez podría agregar yo que podríamos hacer también un bloqueo del plexo hipogástrico inferior.
And of course, as much as we love caudal blocks, this may be a patient that is going to be well suited for spinal opioids, for epidural morphine or a subarachnoid pump
Ujú.
for that type of chronic pain. But certainly the starting point in that patient for me would be a caudal block with a big dose of steroids, 120 milligrams of methylprednisolone and some 1% lidocaine or 1/4% or even 0.5% bupivacaine. Get the patient some pain relief acutely, and then start on an anatomic basis determining which specific nerves are subserving the pain.
De acuerdo. Sí, podríamos colocar un catéter también subaracnoideo, una bomba intratecal básicamente alto. Y pues explorar también la posibilidad de administrar corticoides por vía epidural caudal, siempre combinado con un anestésico local.
Doctor Silver, hay
Sí.
bastantes preguntas. Ya no sé si ha visto el
Ujú.
chat.
Sí, sí, sí,
O
ya,
sea,
ya, ya lo estoy viendo.
usted es libre de
Ok,
poder pues,
perfecto.
hacer las preguntas que quiera hacer.
Ok. Okay,
Eh,
Dr. Steve Waldman, we have other questions. Doctor, this caudal epidural block can use in discogenic lumbar pain.
Absolutely.
Okay. Austria, Javier Alvarado. Failed back spine syndrome. Do you recommend this block for these patients?
To me, it's
Surgery, yeah, was laminectomy.
yeah. To me, it's a starting point
Yeah.
for anybody with lumbar radiculopathy, failed back, spinal stenosis, arachnoiditis. And it's a starting point because it's simple. It's a starting
Mhm.
point because it's safe. It's a starting point because it's well tolerated by the patient. You can use a small needle. You may not, with that first block, maybe you get 40% pain relief. And maybe you switch to a lumbar epidural at some point. But I'm generally going to start with a caudal unless I have a specific pathology that I'm treating. If I know there's an impacted disc fragment on MRI at L3, L4, I'm going to probably focus there rather than with a caudal. But just a patient that comes in that has an acute L5 radiculopathy, I'll start with a
Yeah.
caudal.
Okay, perfecto. Sí, es un bloqueo que puede ser al que debemos de recurrir, especialmente en pacientes instrumentados. La respuesta del doctor es sí, podemos utilizarlo y puede ser seguro. Y en la experiencia clínica, por ejemplo, en pacientes con dolor crónico debido a este síndrome, se recomienda la combinación de puesteroides con lidocaína o ropivacaína al 0.2%. Esto es una opinión por experiencia clínica. Doctor, we have other questions. Can I perform a block using a catheter, and can I leave this catheter for use in post-surgical analgesia, for example, in post-hysterectomy?
Absolutely, keeping in mind that infection is an ever-present risk. And the
Ujú.
longer you leave the catheter, the
Perfecto.
more you increase that risk. Clinical judgment always wins the day, and balancing our compassion with our science is really important in that setting. Continuous caudal block is a great technique. It's been around forever.
Ujú. Sí, sí, por supuesto, pueden realizar esta técnica. Únicamente hay que prestar mucha atención a las complicaciones infecciosas, debido a que si se deja un catéter por un tiempo prolongado, pues incrementa el riesgo de infecciones. Okay, Jensen Cifuentes has other questions. Good night, great team. I have a question. What do you think about use of alpha-2 agonists like dexmedetomidine for longer the anesthetic effect? Do you recommend these drugs?
So there's certainly about every 3 or 4 years there is an anecdotal report or some pretty reasonable studies. We've been, since local anesthetics were discovered, we've been looking for ways to prolong the duration, to make them last longer. And these drugs work. They add a tiny bit of risk. They add some expense. But I wouldn't be, I'm not opposed to it. I don't think it's necessary for every patient, but it's selected, in that rectal cancer patient, anything you can do to prolong pain relief is indicated, in my opinion.
Sí, el doctor dice que existen reportes anecdóticos cada 3 o 4 años del uso de fármacos que prolongan el efecto de los anestésicos locales. Los alfa-agonistas 2 son uno de ellos. No precisamente lo recomienda, pero tampoco está en contra del uso de cualquier fármaco que pueda prolongar la analgesia en pacientes con patologías neoplásicas. Okay, other questions, Fabiola Toledo Caro. What do you think about in the degenerative spine lumbar? What do you think about what is better? Facet block with local anesthetic and corticoids. 2, caudal with corticosteroid and local anesthetic. And 3, epidural is block in L3, L4 with a local anesthetic and corticoids. Thank you.
That comes under the category of a meaning of life question. Within the interventional pain management community, there are some really great clinicians that think you need to put the needle tip as close to the source, the nidus of pain, the source of pain, that you can. There are other people within the interventional pain management community that think start broadly with easier procedures, with more acceptable patient tolerance. The procedures are just less painful. The procedures have less complications. And then as you see how the patient progresses, move on to more anatomically specific procedures. That's how I have chosen to practice. Understand there is no procedure that I'm afraid to do. There's some I won't do because I just think they're too dangerous. But I can put a needle anywhere. I'm not convinced that doing a selective nerve root block as your first procedure, or even you know, even a facet block for somebody with just common everyday lumbar radiculopathy makes a lot of sense as the starting point. Do not
Mhm.
take this as don't take this as a criticism. There's many people that will tell you that Steve is wrong. You should do a L3 selective nerve root block, or you should do facet blocks to start. My
Mhm.
opinion is I would start with a caudal or maybe a lumbar epidural.
Thank you, doctor. Doctor, Waldman dice que, que hay algunos intervencionistas o que muchos intervencionistas están convencidos de colocar agujas lo más cercano a la fuente del dolor. Sin embargo, la opinión personal de él es siempre iniciar de lo más general a lo más específico. Es decir, él sí haría primero un bloqueo caudal. Obviamente, podría poner una aguja en cualquier sitio. Por ejemplo, no está peleado con realizar un bloqueo transforaminal para un dolor radicular. Sin embargo, él prefiere iniciar con algo un poco más general o sencillo e ir haciendo más específico el procedimiento. Específicamente, por ejemplo, para pacientes con radiculopatía. Entonces, es su opinión personal o lo que él practica habitualmente. Ok. Doctor William del Rosario. Ok.
Silver, may I expand just a little bit? When
Yes.
you think about pain relief using neural blockade, using local anesthetic steroid,
Mhm.
the potential mechanism of action may be in part anti-inflammatory from the steroid. It may
Yeah.
be in part neuroplasticity, you know, closing the gate with local anesthetic. It seems logical, may not be correct. It seems logical to me that if you do a simpler procedure that's less painful for the patient, and the
Mhm.
patient accidentally pain goes away, you look like a genius. If it doesn't go away, you get a lot of information. You know what's not going to work, and you know that you're going to have to look further to the source of the pain, if that makes
Ujú.
sense.
De acuerdo. Bueno, sí. Okay. Other questions, Dr. William del Rosario. What is the volume? What is recommended volume for anesthetic and corticoids in caudal block?
12 to 15 ml of 1/4% of Pivocaine. I would start with 80 milligrams of methylprednisolone with the first block, and then with the second block, 40 milligrams, 40
Ujú.
milligrams with the third block, if the patient's seeing incremental improvement.
Ok, perfecto. Unos 15 mililitros, William. Unos 40 miligramos de puesteroide con anestésico local, el de tu elección. Other questions, Beatriz Enciso. Hi, Beatriz Enciso. What recommendation do you suggest in case where the access site is very narrow or highly angled? Is it better not to use that route to avoid tissue injury?
Well, another thing I learned as a resident from one of my faculty members is there was an absolute rule: no poking around. No poking around. So if you have a patient and you look at the patient and anatomically, they've got a big, huge cyst over their sacrum, caudal's not a good idea. If you're trying to identify the sacral hiatus and you can't identify it, caudal's not a good idea.
Mhm.
If you have a patient with significant spinal stenosis, if that's the question that's being asked, not that the anatomy is messed up, the hiatus is narrow. But if the patient has significant spinal stenosis, just like if you're doing a RAX procedure or a lumbar epidural or anything else where you're putting a fluid, local anesthetic, maybe mixed with steroid, in a very non-compliant, non-compressible space, you want to be very careful with volume and very careful with the pressure you inject, or you can really do some harm. You can do some harm. It would be wonderful it would be wonderful if nerve blocks would fix everything. They don't. I just like doing
Yes.
nerve blocks.
Ok. Bueno, si tenemos alguna anomalía anatómica o algún quiste, posiblemente el abordaje caudal no sería una buena idea. Sería una buena idea buscar otro tipo de targets. Okay. Dr. William del Rosario, do you prefer corticosteroids, particulate or not?
It depends on the procedure that I'm doing. It's actually a good question. So the corticosteroid that's been used the most in the epidural space by far is methylprednisolone. Other people would say you should never use particulate corticosteroids in any nerve block or injecting a joint or anything. You should only use non-particulate steroids. I think that's probably a step too far, probably not correct. My vote is to use what you're most comfortable with. By far the most steroid epidurals have been done with methylprednisolone. Probably next is triamcinolone. Probably after that is Decadron.
Yes.
You know, what you should do is use the drug you're comfortable with, understanding that for certain procedures, you should never use a particulate, you know, a cervical selective nerve root block. I probably wouldn't want to use particulate steroids, although probably a million of them have been done, but when it goes wrong, it's not good.
Yes. Sí, el doctor dice que puedes en realidad usar cualquier corticoide con el que te sientas cómodo. No está en contra del uso de los corticoides particulados, especialmente en el hiato sacro, pero sí hay que tener cuidado con el uso de los corticoides particulados en algunos sitios específicos. Podría agregar por la experiencia clínica y por los lineamientos internacionales, no aplicar los corticoides particulados por arriba de L2. Ok. Dr. José Daniel Suárez Plata, what do you think about the prolotherapy in caudal space for lumbar chronic pain?
I really have no experience with it. I'm not a prolotherapy expert, so I'll defer to anybody in the audience that has had good experience with it.
Yes, el doctor no tiene mucha experiencia utilizando proloterapia por vía caudal. Sin embargo, si puedo agregar un poco de mi experiencia clínica, se puede utilizar dextrosa al 5% como una especie, como washout, como para hacer un lavado de citoquinas y podemos tener buenos resultados. Incluso en pacientes en los que se pretende hacer un procedimiento para dolor crónico, en el que además utilices algún tipo de medicina regenerativa y no desees usar corticoides, es una buena alternativa hacer un abordaje con dextrosa al 5%. Okay, Dr. Gauke, what kind of steroid do you prefer to use in the caudal block? I think that a doctor has answered this question.
Methylprednisolone.
Yes, metilprednisolona.
But
Maximil-
if the doctor that asked the question says, Steve, you're an idiot, I think you should use triamcinolone, I wouldn't argue, you know. We all do. We all use what we're used to. Maybe that's good,
Yes.
maybe it's bad, but I think when you venture out into things you're not familiar with, it's very easy to make an error.
Yes, yes. Doctor says él usa metilprednisolona. Sin embargo, en realidad, pues puedes usar con lo que estás más acostumbrado. Hay lugares en los que no hay metilprednisolona y hay triamcinolona y no hay ningún problema por usarlo. Finalmente es un corticoide particulado. Maximiliano, have you any experience with the use of prolotherapy? Doctor says not before. Okay, one more question. Piero Canepa. This is this block can use to take the previous decision about to put alcohol or chemical neurolysis in sympathical ganglion in the sacral site or the Walter ganglion. This block can use for take the decision.
I didn't understand the last part. This block can be used for.
Okay. This caudal block
Yes,
can use for take a decision for in a future time perform neurolytic block in the
I understand.
in paraganglion.
So the caudal block is a good prognostic indicator if a neurodestructive procedure of the ganglion of Walther, ganglion of Impar, is going to be successful. If you really, really, really numb, if you put 20 ml of local anesthetic in the caudal canal and the patient says, I'm still having rectal pain, I'm not telling you that the ganglion impar block will not work, because there's sympathetic fibers that need to be considered, but I will tell you it probably won't work. And I certainly would not start with a neurodestructive procedure on that patient. I would do a local anesthetic ganglion impar block and see if they get pain relief. And if you're not sure and if the patient, if it just isn't, if you're not feeling 100% confident, you might come back and do the procedure again with a different duration of local anesthetic, a long acting like 0.75 bupivacaine, a small amount, or do it with a maybe saline. If you're not sure, don't destroy anything.
Yes. Sí, o sea, puede ser un indicador de buen pronóstico. Sin embargo, cuando se hace un bloqueo epidural caudal, pues no se consideran algunas fibras simpáticas, por lo que sería más conveniente realizar un bloqueo del ganglio impar, o sea, un bloqueo simpático con anestésicos locales, y decidir en base al resultado de este bloqueo si se realiza o no un procedimiento neurolítico. Thank you, doctor. Other question. Doctor Gerardo Solís, un saludo a mi amigo Dr. Gerardo Solís. Doctor, thank you very much for your teachings. My question is for patients with painful diabetic neuropathy and associated painful symptoms. Is this technique an approach useful for administering some type of therapy, drugs, or substance, sterilization, ozone to reduce these symptoms or any of them?
So as we all know, diabetic polyneuropathy is difficult to treat. Generally, the first line treatment is going to be pharmacologic, using gabapentin-like drugs, anticonvulsants, antidepressants. If a patient is really is suffering, it's worth a try. It would not be, the success rate's probably above placebo. But it's not going to be like acute herpes zoster where they're going to really get relief quickly, or a big thrombosed hemorrhoid where they're going to get relief quickly. But it's a consideration. It's simply, it's so much easier than doing a lumbar sympathetic block, for example.
Ajá. Obviamente sabemos que la neuropatía diabética se trata inicialmente con fármacos, con gabapentina. No, tal vez el bloqueo caudal no sería la mejor indicación, tal vez no tendríamos tanto éxito como en un procedimiento, por ejemplo, de piso pélvico, una hemorroidectomía, etcétera. Y posiblemente en este tipo de pacientes podríamos más bien considerar un bloqueo simpático, Gerardo. Bien, we have other questions. Enildo Rosario, good night from Dominican Republic. Can I use the peridural block to treat the pelvic chronic pain?
Sure. So as I mentioned earlier,
Yeah.
let me back up. Chronic pelvic pain is a very complex decision to treat. There's some pictures of my books. One of the books is on pelvic pain. The more confusing the diagnosis, the more careful you have to be with your therapeutic interventions. And chronic pelvic pain is one of those. Again, if you do a caudal epidural block with a reasonable dose of local anesthetic and the pain doesn't go away, it doesn't mean that the pain isn't real, but it means that thinking about doing a ganglion impar block or hypogastric plexus neurolysis, probably not. It should probably move down on your list a little bit. If the pain goes away, you immediately give the patient hope. You can then start trying to work on what's causing the pain and what long-term solutions are available.
Ok. El dolor pélvico crónico, comenta el doctor, que es una enfermedad muy compleja, por lo que al hacer un bloqueo caudal sí podría aliviar el dolor. Sin embargo, si al realizar un bloqueo caudal, epidural caudal, no existe alivio del dolor, no significa que el dolor pélvico pues no sea real. O sea, más bien la estrategia terapéutica debe ir orientada a otras estructuras que pueden estar participando en el dolor, como el ganglio impar o el plexo hipogástrico superior. O sea que sí puede ser una opción para el tratamiento de él, pero como es una patología extremada compleja, es mejor identificar la estructura que está generando el dolor y realizar tratamientos un poco más específicos. Bien, other questions,
Doctor,
Dr. Gerardo. ¿Sí?
doctor Silver, si quiere,
Yeah.
pues puede leer una última pregunta.
Okay, una última pregunta. Last question, doctor, sorry. Doctora Catherine Quevedo from Peru. Good night, Catherine. She has a question. Good evening, excellent presentation. How you place a caudal tunnel catheter? In which case, and how long did it last?
So you place a caudal catheter in a manner analogous to placing a lumbar epidural catheter or brachial plexus catheter. I'll go step by step, Silver, okay?
Yeah.
So position the patient as we discussed.
Yes. La posición del paciente ha sido descrita previamente.
Using sterile technique.
Usa técnica estéril.
A 3.5 inch 18 gauge Husted or TUI needle.
Ujú. Utiliza una aguja de 18 gauge, técnica estéril. Ok, a una
And
aguja TUI.
yeah, numb the patient up first. I forgot that. And simply place the needle, the styleted needle, through the sacrocoxageal ligament.
Ujú.
Rem-
Simplemente coloca la aguja a través del ligamento, retira el estilete. Ujú.
Remove the stylet.
Ok, remueve el estilete.
And then simply gently thread the catheter past the tip of
Desliza,
the needle and
des-
advance it an inch and a half, 2 inches.
ok, introduce el catéter a través de la aguja. Ujú.
And then and while securing the catheter, carefully remove the needle.
Asegura el catéter y remueve cuidadosamente la aguja.
And then secure the catheter.
Asegura el catéter.
And then do a small test dose of local anesthetic.
Realiza un test con una pequeña dosis de anestésico local.
Perhaps epinephrine containing. I don't think it's mandatory, but if it gives you, makes you feel more safe, looking for
Ujú.
tachycardia.
Puedes administrar una cantidad pequeña de lidoconepinefrina como dosis de prueba, aunque no lo considera obligatorio,
And then you can
buscando taquicardia.
then gently dose the catheter with small incremental doses of your local anesthetic of choice, watching for any sign of local anesthetic toxicity.
Incrementa la dosis en escala pequeña, o sea, incrementa la dosis con poco volumen, viendo algunos efectos secundarios.
And you can use do a continuous infusion with a pump. The other part of the question is how long would you leave it in? No more than 48 hours without tunneling.
Ok, puedes colocar una bomba de infusión, un home pump, pero se recomienda no dejar pues más de 48 horas el catéter.
Bien. Doctores, muchísimas gracias de verdad doctor Silver, quiero agradecerle infinitamente por esta magnífica colaboración. Sé que fue un interlocutor pues sumamente bueno para el doctor Waldman, y de seguro los asistentes del seminario han podido aprovechar muchísimo toda esta exposición del doctor Waldman. Doctor Waldman, thank you very much for your presentation and for
Hey.
being here with us. On screen, you can see the latest book published by Amolka, um, the physical diagnosis of pain, diagnóstico físico del dolor. Can you share a few words about your book, Physical Diagnosis of Pain, Dr. Waldman?
Yeah, everybody across Latin America should buy a copy. No, just kidding.
Yes.
So physical diagnosis is really if you really want to get patients' pain better, you have to know how to examine the patient. At least in the United States, and I suspect across most of Latin America, we've come to rely on testing, MRI, CAT scan, ultrasound, and we forget to take a history and examine the patient. This textbook really breaks down in a very simple, straightforward manner physical diagnosis tests that will help give you the answer. And we can come back sometime, we can talk about physical diagnosis. We can come back and talk about, rather than a procedure, pain. Facial pain would be a fun one. abdominal pain anytime. It's been such a pleasure, and I appreciate it. I appreciate it. If you have questions, just email me. I'll try and answer them.
Bien, doctor. Thank you very much for your time, doctor Silver. Creo que nos extendimos un poco más del tiempo, pero igual agradezco muchísimo
No problem.
su colaboración, de verdad que ha sido muy, muy valiosa. Y bueno, tienen allí en pantallas pues la última edición de la que habló el doctor, de eso que no se debe olvidar para el tratamiento de los pacientes. El libro Diagnóstico Físico del Dolor, Atlas de Signos y Síntomas, es la quinta edición del libro. Pueden obtener información en el código QR que estamos compartiendo allí. Hay una oferta disponible que varía pues en cada país y es una oferta exclusiva vía atención directa por WhatsApp y válida por 48 horas. De nuevo, muchísimas gracias a todos los asistentes. Muchísimas gracias, Dr. Silver. Thank you very much, Dr. Waldman, for your time and for sharing your knowledge with Latin American people. Y bueno.
Anytime.
Thank
This
you.
was fun. Anytime, I'm happy to do it.
Thank you so much, Dr. Wallman.
It was
Thank
fun.
you.
All right. God bless.
Thank you.
Chao,
Bye.
chao. Muchísimas gracias.
Chao.
Chao.